ABGs are one of the most useful tools to evaluate a critically ill patient with a respiratory or metabolic disorder. A key aspect of ABGs is that it eliminates guesswork from clinical assessments of ventilation and acid-base status, and it can reliably demonstrate either a pulmonary disorder, a metabolic disorder, or both. So if we break it down pretty simply, we've actually discussed all of the processes that are in an arterial blood gas, so it really shouldn't be too much of a surprise that the purpose of an arterial blood gas is to measure alveolar ventilation, oxygenation, and acid-base status. In some sense, the purpose of all these lectures has been to introduce you to understanding ABGs as a central key message of evaluating a critically ill patient. So let's dive in to acid-base disorders by talking about the law of mass action. And the law of mass action shows an interesting relationship between CO2, bicarbonate, and acid. So bicarbonate is something that is made everywhere in the body, but it is mainly produced and retained in the kidneys. And its purpose is to deal with excess acid. So this is a base, a weak base inherently, and this is an acid. And if there are too many protons hanging around, then this what's called bicarbonate buffering system kicks into gear and is able to shuttle an excess proton through this equation to the left and make either CO2 or water. And water can be used for pretty much anything in the body. And if there is more CO2 that is produced, because the only way that CO2 is able to be excreted from the body in the lungs, the body is able to breathe it off. So acidic processes can come in many different forms in the body, from gastrointestinal processes to medications to ingestions, etc., etc. But for the purpose of understanding acid-base in this lecture, the two main variables that I want you to pay attention to is bicarb and CO2. We already know that CO2 can be increased and can be decreased in the system, and this primarily says that, and this is done through ventilation. So overall, if there is an increased or decreased amount of CO2, what we're talking about is a respiratory process. And I should say same thing with bicarb. It can be increased, it can be decreased in the system. It can be lost through things like urine, it can be lost through things like stool or chronic kidney disease. It can be increased through retention in the kidneys on a normal basis. And ultimately, if we're talking about HCO3, because the primary mediator of this is the kidneys, this is a metabolic process mediated through the kidneys. One way to understand this relationship is the Henderson-Hasselbalch equation, which I won't belabor, but just to kind of pay it respect. Actually, this should be minus. And what this is saying is it's kind of showing the relationship between these three variables. That ways that you can have an acidosis, or a process where there is a decreased amount of pH in the system, can be a reduction in bicarb, or an increase in PCO2? And how about an alkalosis? This is where you can have an increase in bicarb or a reduction in PCO2. And what I'm not really mentioning is that you can have combinations of both of these, but this is a really nice kind of basic understanding of the relationship between these three. So in summary, there are two main variables for the purpose of this lecture that we're going to use to talk about acid-base disorders. And the second is that they can both influence one another. Each other by the process known as compensation. So for example, if there is a respiratory acidosis from a ventilatory defect, then the kidneys can kick in and provide more of a base molecule, that weak base of bicarb, to try and balance out the acid-base status of a person, and vice versa. Let's see if we can look at a couple of brief examples of both acute and chronic respiratory disorders and how the kidneys kick in. This is a great illustration to help you decode ABGs in terms of a primary process and a secondary compensatory process. And so anytime that you have somebody that shows up with an abnormal pH, you need to ask the question, is it a primary respiratory problem that is causing this, or is it a primary metabolic issue which is causing this abnormal pH? And the second thing is, once you've determined what the primary process is, what is going to be the appropriate buffering system which is going to initiate here, or what's the compensation that you should expect to see? So if somebody has a low pH and we've determined that they are acidotic, we need to ask ourselves, are they acidotic because they have high PCO2, meaning that there's a ventilatory defect, or if they have low bicarbonate, meaning that there's maybe some sort of GI issue, or there's some sort of kidney issue. If they have a high PCO2, we determine this to be a respiratory acidosis. If they are acidotic, that means the body is going to respond by increasing the amount of base, or making a metabolic acid alkalosis. So what they will do is increase the amount of bicarb in the system by retaining it in the kidneys. If the patient is acidotic because of a low bicarb level, then we determine this to be a metabolic acidosis, which means they have lost a fair amount of HCO3, and this can be to a high amount of acid in the system or other reasons. If they have a metabolic acidosis, then what will happen is that the lungs will try and balance out this acid base by reducing PaCO2 or reducing ventilation. Now you can do this on the other side. So if somebody has a pH which is elevated, you've determined that they have more of an alkalotic disposition. Are they alkalotic because they have a high amount of bicarb, or because they have a low amount of PCO2, meaning that this is hyperventilation, or that they are somehow retaining high amounts of bicarb? So if they have a respiratory alkalosis, they're blowing an awful lot of CO2. That means the body responds by reducing the amount of bicarb in the system by dumping it in the urine. On the flip side, if they are alkalotic because of a high level of bicarb in the system, you can have a metabolic alkalosis and the body responds with a respiratory acidosis, which means you are going to reduce the amount of ventilation in your system. So that's why when we have acid-base disorders, we need to look at the pH, the PCO2, and the HCO3 in order to get the best idea of what's going on. The purpose of knowing and understanding the buffering system is to understand whether the process is acute or chronic. If the buffering system has kicked in, this is a chronic disorder. So anytime we write an ABG, we write pH followed by PCO2 followed by PaO2 followed by bicarbonate. So you would typically see the numbers 7.4/40/90/24, and these are all normal numbers. Speaking of normal numbers, we have the ranges written here. And if we were to start with the pH normal range is 7.35 to 7.45, and if we were to cut that in half, we'd come up with 7.4, which I've written here. For oxygenation, PaO2, the middle number here is about 90. The middle number of PaCO2 is 40. And the middle number of bicarb is about 24. So I would like you to memorize these numbers. These are important. So as we go through these, remember in order to identify that primary process, and we're going to stick mainly with the lungs, but I'm going to demonstrate both the lungs and metabolic processes here, so you get the flavor of it. You are always going to begin with that pH. So we've identified them as acidotic. And if they are acidotic, are they acidotic because of the lungs or because of a metabolic issue? So what is the primary thing? So here I see a PaCO2, which is elevated, and a bicarb, which is within normal range. So we can estimate that this is an acute respiratory acidosis. And the reason I'm saying acute is because I don't see any evidence of any compensation here. The next one, again, we have an acidotic state. And again, the question is it acid because of the lungs? Are they retaining CO2, or bicarbonate? Is it dumping bicarbonate? And what I see here is I see an elevated number for CO2, and I see a little bit of an elevation here in bicarbonate. And what this means is that we have a respiratory acidosis with compensation. And the reason I say compensation again is because we have evidence that this bicarb is trying to balance out this number, and you can actually see that there's been a small increase from 7.30 now to 7.34 if we say that this is the same patient. So I would write this as chronic respiratory acidosis. And it takes, as a note, it takes between 2 to 3 days for the kidneys to kick in. Now what I'd like to do is to talk about the next set, and we'll also say that this is the same patient. Starting with the first one, it appears that we have an alkalosis because it's above that 7.4 number. And the question is it alkalotic because of a lung issue, or are we blowing off a lot of CO2, or are we retaining a lot of bicarb? And so what I see here is a normal bicarb number, and I see a very low CO2 number, which means we have an acute respiratory alkalosis. And here, let's say that this is hours to days later, we see a mild improvement in that pH. And again, we're looking at primary process and understanding that there might be a compensatory process that is coming on. So we still have an alkalotic state. We still have this reduction in CO2, which is making this alkalotic state, and now what we have, or I should actually say here, is that we have a drop in bicarb, which is a way to try and buffer and even out this alkalosis. So we have evidence of compensation. So this would be chronic respiratory alkalosis, or you could say respiratory alkalosis with compensation. Both of these are correct. Let's see what it looks like on the next page when we see the lung being used as the buffering mechanism. So next what I'd like to do is I'd like to explore how the lungs can act as a buffering system for a metabolic derangement. So in order to do that, we have our normals. I'm going to write our normals up here. We've got 24, 40, and 90. And I'd like to treat these numbers as two patients, patient A and patient B, and this will be over the course of time. So we're going to take the same approach as we did in the last slide, is we are going to look at our pH first, and we're going to see that overall this patient is acidotic. And the first thing we're going to do is we're going to look at both the lungs, and we're going to look at the kind of the metabolic markers, and we're going to see which one is the most egregious here and which one seems to be the primary process. So here I see that bicarb is quite low, indicating a metabolic acidosis, and here I see that the lungs have not really compensated for this yet. So this I would label as a metabolic acidosis, an acute metabolic acidosis. Now over time we can see that the lungs will respond by reducing their PCO2 by increasing their ventilation. So somebody would be breathing a lot faster with a with a metabolic acidosis to try and relieve themselves of all of the excess hydrogen atoms or protons. And so what we see is that compensatory mechanism, it hasn't improved things a tremendous amount, but it has helped kind of improve homeostasis. So here we see the lungs serving as a buffering system, and here this would be a chronic metabolic alkalosis. Moving downward, checking the pH in patient B, we can see that this is an alkalotic patient. And I would actually just like to say that this is acidosis, pardon me. In patient B, we have a pH which indicates an alkalosis. We're going to check both systems or organ systems to see which one might be the primary derangement, and we see that PaCO3, for whatever reason, is now elevated. And if it's elevated, and we don't see any evidence of the lungs being involved, then this would be an acute metabolic alkalosis. Now, over time, we can see the kidneys kicking in by reducing ventilation. And what this does is this impacts the pH overall, so we do see some improvement. So here you would see a chronic metabolic alkalosis, which we can also call metabolic alkalosis with compensation. And so between this slide and the last slide, we can see how the lung can be used both as a primary mechanism, be the primary kind of focus of acid-base derangement, as well as be involved in the buffering or the compensatory system to try to reestablish homeostasis. And lastly, what I wanted to do was to kind of give an homage to acid-base nomograms. And what a nomogram is a graphical illustration of the relationship of PaCO2 and bicarbonate. So here on the x-axis we have an increasing partial pressure of CO2, and on the y-axis we have an increasing bicarbonate level of bicarbonate, excuse me. And so smack in the middle, right here, we have this sweet spot of the normals of both bicarbonate and PCO2. And the interesting thing about this nomogram is that if you begin shifting one or both of these variables, you can wind up demonstrating kind of territory or real estate of this graph, which represents different types of acid-base arrangements. For example, acute respiratory acidosis is when PaCO2 is elevated and bicarb is not. Another example would be chronic respiratory acidosis is when PaCO2 is elevated and bicarbonate is elevated as well as a buffering system, so that's why we list it as chronic. Up here we have acute and chronic metabolic alkalosis, which means that the primary derangement is going to be a bicarbonate issue or a metabolic issue, so there is a rise in bicarbonate, and it is met by an increase in PaCO2. And the list goes on, and you can kind of go through the rest. But this is an interesting graphical illustration of all of the different types of acid-base disorders.